Good morning. Thank you for joining us for today's webinar hosted by the MD2K's a center based at the University of Memphis. I'm Vivek Shetty, Training Core Director for the MD2K. Today's webinar, Who's in Your Data? Data and Machine Learning Limitations in Health Research, will shine a light on the dark side of the promise and potential of big data. Specifically, the potential of algorithms to perpetuate health inequities and historical biases. For a thoughtful discussion, we have invited a rising star, Professor Elaine Nsoesie of Boston University. She is a big data science faculty fellow and part of the BU Data Science Initiative at Boston University. She uses digital data and machine learning to improve population health and applies data science methodologies to global health problems, particularly in the realm of surveillance of chronic and infectious diseases. So, Elaine, up to you. Thank you.
Thank you so much for the introduction. Is that okay? Can everyone see that?
Yes. Thank you.
All right, great. So today I'll talk to you about data and algorithmic bias with more focus towards digital data because that's what I've been working on. I'll start with a hypothetical example. So let's think of a woman named Angelina. She's 45 years old. She has 3 jobs. She has no health insurance, so it means that she's less likely to go to the hospital unless she has a very serious medical condition. And so she's probably not being captured by electronic medical health records. She also doesn't use social media very much because she doesn't have the time. She's very busy. So now let's think about these at a community level. So let's say we have an entire community of people who do not have access to health insurance, and so they're not going to the hospital as often as they need to. In addition, they're not using social media as much, or maybe they're using social media, but they're not sharing health information on social media. So what would happen if we wanted to estimate a particular health condition, so the prevalence of a particular health condition in this community? We'll definitely have issues if we're looking at these 2 data sources because these individuals are not being captured in these data sources. And this is what happened in a study where researchers were interested in estimating influenza-like illness at different zip codes across the US. So they looked at 3 data sources, data that came from the traditional ILI surveillance system created by the CDC. They looked at Biosense 2.0, which I believe contains electronic health records. And they looked at data from Google Flu Trends. So if you don't know about Google Flu Trends, it's a system that was developed by Google to track trends of influenza-like illness in the US. And the way it works is they collect searches from for particular terms that are correlated with influenza-like illness based on CDC data, then construct a model that's supposed to estimate influenza-like illness over time. And what they found was that irrespective of the data source that they were looking at, their predictions were best for zip codes that were most affluent and not so good for the impoverished zip codes. And one of the reasons is probably the fact that many of these individuals in these lower income zip codes are not being captured in these systems. So if we're building a system, for example, where we say we're using social media data to estimate influenza-like illness, and our validation data is hospital data, if someone is not using social media or not posting health information on social media, then they're not being captured in that system. And also, if they're not going to the hospital, they're not being captured in that system either. So we might build models that show very good correlations between these 2 data sources, and it looks great. But when you start looking at the underlying data, where is it actually coming from? We end up seeing that the communities are not being represented because they're not using either of the systems. So when I think about data bias, I think about it from the data collection process. So how is the data being collected? What kinds of questions are we asking when we collect the data? How are we thinking about representation when we collect data? When we're working with social media data or data from hospitals, we don't really have a lot of control how that data is being collected, but we might have more control when it comes to how the data is being processed. So for example, if you are looking at state level data for a particular state in the US, and you notice that there are counties where you have 0 records, is it okay for you to just drop those counties from your data set and go ahead and conduct your analysis? What kinds of biases would that introduce to the machine learning algorithms that you then use to make decisions? So if your data is biased, then your machine learning algorithms are going to be biased as well. So what are the assumptions that are being made when we're developing machine learning algorithms, and how is data playing into the biases that then end up coming out of those systems? And this would definitely influence services and policies. So if our data is only capturing particular populations, then the services and policies that we implement will probably be most beneficial to those populations. And the individuals that are not being captured in our data sets or that are being dropped because they're not represented will not benefit from these services. We all know that there's a lot of data out there. A lot of health happens outside of the health system. There's a lot of thinking around how do we bring all those different data sources, whether it's personal health records, home treatments, how do we link all of these to the data that we have from healthcare centers? And this is very exciting because it can have significant impact on both individual and population level health. But while there are all these great things that we can do with this data, there's also the potential of misuse. So let's talk a little bit about social media data as an example. So in the US, we have about 208 million social media users based on data from 2017. And this covers a lot of young individuals, 18 to 29-year-olds and 30 to 49-year-olds on different systems. Which means that we can get a lot of data from these systems for health purposes. But just because our data is large doesn't mean that we capture everyone. So big data does not automatically translate to representation. So it's still important for us to think about what populations are posting on these websites. So you have different age groups would use different tools, and the way in which these tools are used are different across age groups, but also differ across gender and also racial groups. There's certain populations that have had their data misused in the past who tend to be more hesitant in posting personal information on some of these platforms, while there are others that would post everything about their health. And so when we collect this data for research purposes, those are the individuals that we tend to capture. So just to give you some examples of how data has been misused in recent years and the things that have appeared in the news. So there's obviously the Cambridge Analytica scandal with Facebook that people have been talking about now for years. There's another example with OkCupid where they matched individuals to their wrong matches. So instead of matching individuals to the matches where so this is for dating purposes. So instead of matching individuals to the persons that the algorithms recommend, they would match them to individuals that are mismatched and then see what happens. So there are all these experiments that are being conducted by companies that can influence us in different ways, including affecting our health. There's also the Facebook emotional contagion where they were curating people's messages to see how they react to it. And then there's been a lot of talk about misinformation on Google from advertisements about health treatments that are very incorrect to how our data can be easily manipulated to affect how we think and how we react to different things. I wrote about this recently in the Public Health Post, thinking about how much data we put out there and how companies can use this data in ways that influence our health. So one example that I was thinking about is around women's health. So let's say a woman gets pregnant and she's very excited. So then she signs up for a pregnancy tracking app, and then she has a miscarriage. So then obviously she stops entering information into this pregnancy app, but she continues to receive reminders over time, and she deletes the app from her phone, but she still gets email reminders. So how can we measure how these kinds of messages can affect her mental health? So she might think she's recovering very well, but because she keeps getting all these messages, she starts dealing with sadness and depression. How do we measure how this information that we're putting out there and that's used to feed back to us all that algorithms think, or algorithms do not actually think, that individuals that have developed these algorithms think can provide new useful information that can be useful to us. So this leads to the question of how do we responsibly mine and ethically study digital footprints to improve population health? There's been a lot of conversation about ethical guidelines for use of health data. And these, I copied this from one of those papers. And in this case, they list specific guidelines on how people can think about data and how they can use data in a way that's responsible. And one of those guidelines is to be transparent. So make sure that objectives and methods and data handling practices are transparent and easily accessible. They talk about respecting what people put online. So if someone wants to remain anonymous, or if they have information that they don't want other people to see, then it's important to respect that. They also talk about IRB, which is very important, especially when we think about the data that we get from social media sources. But IRB, in most cases, when I do research, I'm usually exempt, unless if I'm contacting someone directly, I usually get exempted from actually getting IRB approval for most of the studies I do. So that's something that's still very important to think about, since different people have different views on how their data is being used by researchers for health purposes. Another area that has been discussed is the need for methods that allow for rigorous analysis, because standard statistical methods are not always appropriate. So we can get data in so many different forms, from text data to image data. How do we process that data? How do we integrate those different data sources? But also, how do we develop methods that allow us to quantify our uncertainty in the estimates that we provide? So a lot of the machine learning methods that I use usually will give an accuracy, or you get an F1 score, but there isn't a measure of how much I trust the estimates that are coming out of those models. A third area of discussion is around developing approaches that would allow us to easily integrate data from different sources. So we have data coming from mobile apps, from the internet, and from other types of technology. How do we put them together in a way that would be useful for different individuals that are using these data sources? And lastly, the area that I've been thinking about for the last few years is the need to assess whether our data is representative of the populations that we. So on the right is a visualization of a survey that we conducted, and we just asked a question to people about whether they actually tweet personal health information. And we found that there were differences in males and females. So females appear to be more likely to tweet about personal health, while males tend to be less likely. So this was done more at a national level. And for most of the work that we've been doing since then is thinking more either at the county level, depending on how much data we get, or even going more granular and looking at disparities across different demographic groups. So I'm going to go ahead and give you two examples of studies that we've conducted in this area. One of them is on foodborne illness surveillance. So we've been working in this area now since 2014. And the idea is to see how data that comes from sources like Yelp and Twitter can help health departments in surveillance of foodborne illness. A lot of people get affected by food poisoning. So it's not a particular group of individuals in the US or globally that get affected by food poisoning. Everyone is exposed. But the rate of reporting tends to be really low, either because individuals report to health departments or because it takes too much time to go through that process. But people would tweet about it, or if someone eats at a restaurant and they get sick, they would usually go to Yelp and write a review about it. And we know that this is the places that people implicate and not always the places where they are sick, but we tend to look at groupings of reports. So if you have 6 people go out and eat and they all say they got sick, then that's a much stronger indicator that they probably all got sick from the same place. But if you have a single person saying that they got sick from that place, if you don't have other reports happening over time or around the same time, then the likelihood that they actually got sick from that particular place might be lower. And so this is just an example of the kinds of information that we're looking at. So this is someone who said, they went to an Indian restaurant and had food, and then they got sick. So this information is not only being used by academic researchers, it's also being used by health departments in the US. An example is New York City Health Department. They've been using this information to monitor food poisoning in New York, and have been able to identify outbreaks that were not being reported into your system. You also have examples from Chicago. Chicago has used this system for more targeted restaurant inspections. So if you have many people saying that they got sick from eating in a particular restaurant, they can actually go in and do an inspection to make sure that the restaurant is okay. And I've been interested in how is this data capturing, how are different populations represented in this data? So is this data only benefiting the rich or the people from higher socioeconomic backgrounds, or is it also representing individuals from lower socioeconomic? So for this particular study, we looked at Yelp reviews from 2004 to 2014, and these are all the Yelp reviews that were available for these 3 states, Oregon, Georgia, and Massachusetts, and there are approximately 1.5 million reviews. And what we were interested in is to see whether there's a correlation between Yelp reviews, reports of food poisoning, and various socioeconomic factors. And what we found was that factors that tend to be associated with affluence, such as higher income and having a bachelor's degree, tend to also be more positively correlated with foodborne illness reports. And this is important because individuals from lower socioeconomic backgrounds usually tend to have higher risk of foodborne illness for multiple reasons, but they are also the ones that are not being captured in the healthcare systems, but also in the social media systems. So just to show you this visually, I don't know if this is easy to see, but the factors such as unemployment, percent uninsured, percent poverty that tend to be associated with lower socioeconomic status are the ones that are negatively associated with reports of foodborne illness. Then the ones that tend to be positively associated with higher socioeconomic status are the ones that also tend to be more positively associated with reports of foodborne illness in this platform. So to show you this visually as well, so this is an example for Georgia. On the right, we have Yelp reviews in Georgia, and on the left, we have poverty in Georgia. So this is percent below poverty line. And what we find is that counties where you have the highest percent below poverty line, and also places where we tend to have little to no data. Another topic that we've been working on has been around behavioral risk factors for chronic conditions. So there's a lot of data that people put on social media about what they're doing and how they think about different factors that could contribute to chronic diseases such as obesity or cardiovascular disease. And we've been looking at this data to see whether there are gender differences across the US. So just to show you what a tweet looks like for those of you who don't use Twitter. So on the right is an example of a tweet. You can get information such as the Twitter handle, the date and time of the tweet, user profile picture, hashtags if those are used, number of likes and number of retweets, etc. So those are explicit data that you can get about the tweet, but there's also explicit data that you can get about the user. So you can get your Twitter handle, the language that's being used, the time zone, location, date account was created, etc. All this are useful information depending on what kinds of research questions you're asking. There's also extractable data about the user, so things like disease state. So if someone says, I've had the flu for 3 days, that could be useful information. People have also used the types of explicit information from the user to estimate things like gender, marital status, political parties, etc. And then there's also information that you can extract about the tweet. So you can obviously get the tweet content, and you can do content analysis to identify specific topics if you have a large data set. You can also do sentiment analysis to see what people think about different topics, image analysis, and language analysis, and so forth. So for this particular study, we worked with researchers from the University of Maryland. They had collected 80 million tweets on several different topics. And one of these topics was food. So these are examples of the kinds of tweets. So someone says, this week is crazy busy, so I'll be making this fast and super healthy crock pot pulled beef. So that's information that is useful and then is captured in our database. And to capture this information, they use 1,430 keywords from the USDA's National Nutrient Database. So after cleaning all that data, we ended up with about 4 million tweets. We did something similar for physical activity as well. So we had 376 keywords from common fitness questionnaires and apps. And based on that, we collected millions of tweets and then went into the data and cleaned the data up and then ended up with about 1.4 million relevant tweets. So the next step in this study was to determine gender based on the information that was being presented. So there are several different methods that can be used for inferring gender. Some of these methods use a lot of information from the user, so we look at the user's entire network to improve accuracy. But then there are also methods that just look at people's names and usernames and what color preferences they have on their profile to make inferences. So we had a label data set that we used to train our machine learning algorithms. So all the methods, 3 methods that we had focused on names and usernames. The first method matched that information to Social Security information. So we got Social Security data on what names are usually assigned to girls and what names are usually assigned to boys. And then we used that to infer whether someone was male or female. And then the second method looked more at how names are constructed. The second and the third method, you looked at how names are constructed and use that information, so the linguistic structure of the names, to make inferences about whether they're male or female. The different methods had different coverage. So we had one method that was able to cover all individuals, but there's another method that couldn't cover all individuals because not everyone actually would provide a usable name. So people sometimes use other names that are not actually their names, or some of the usernames might not be useful for making any information. But when we put all those methods together in an ensemble classifier to get a single final output, we're able to cover the entire data set. So for every individual in our data set, we're able to get a classification of whether they were male or female. And the accuracy and the recall for that was about 84%. So this is some of the results that we have. And this is broken down by region. So we have Midwest, Northeast, South, and West. And we have this also for females and males separately. There are certain types of activities that you can see that are consistently represented across regions. So those are activities like walking and this one is dancing. And then there are other types of activities that are less represented in some regions. So things like golfing appear in some regions, but not so much in the others. And then there's types of outdoor activities that people tend to do more in some regions and in others. And this is important for several reasons, one of which being that if someone is thinking about doing web-based interventions for physical activity, it's important to know that there's regional differences. It's even more important to know if there's state-level differences or county-level differences and how those differences can influence the kinds of interventions that you can. It's also important to know how these different individuals are using these platforms. So the females tend to talk more about certain types of activities than others. And that's something that we did see. So what we found was that in most cases, males tend to talk more about CrossFit than women tend to talk about CrossFit, while women will talk a little bit more about things like yoga than men talk about yoga. Another analysis we did was to look at the calories consumed. So for every food that was reported, we could go back to the USDA and get an estimate of calories consumed. And so we did that for all the different foods that were available in our data set, and then looked at the differences between males and females. So this is at the state level, and you can see that in most states, there are very significant differences for males and females. What we found is that females tend to talk about foods that have higher calories than males tend to talk about on social media. There are many different reasons for this. It could be, so one of the reasons that we found just looking at the tweet content is that women would talk about feeling bad after eating something that was of higher calorie if they were on a diet. So they would talk about that, and that would be captured in our data set. There were also instances where people will go out to brunch, and so we'll report that on social media, and the types of foods that they consumed at brunch would tend to have higher calorie content. So this is also a very important risk factor. We know that this data, just because someone posts something on social media doesn't mean that it's absolutely true, but it's still important to know that those differences exist if we're going to use this data, whether it's to estimate these risk factors in the future or in the present at different geographical areas. So we also looked at calories burned. So similar to the exercises that people were saying that they were engaged in, if we translate the exercises to, let's say, 30 minutes of exercise for an average American adult, what does that translate into in terms of calories burned? So we obtained that data for every single post and then averaged that and got these distributions for males and females for every single state in the US. So there's some similarities, but there are also differences. So for some states, you have males talking about exercises that tend to be more of higher intensity, while women talk about exercises that tend to be a lot lower in terms of intensity. One other thing we did was look at the distribution of the different outcomes that we're interested in. So we looked at exercise tweets, fast food tweets in general, and healthy food tweets. And we compared this for males and females. And we broke this into three different groups, three equally distributed groups. And we wanted to see how this differed for males and females, but then we also wanted to see how this differed across household income. And what we found was that communities that tend to have the lowest household income, median household income, also tended to have the least amount of data in our data set. So if we're making inferences across those communities, it's important to know that, so we can actually talk about those limitations, acknowledge those limitations in our studies, and then maybe talk about ways in which we could start to address those limitations. So as I mentioned before, if we have data that is over-representative of one population, then the conclusions that we draw are going to favor that group. The implementation of interventions also will be affected, because we would only be implementing interventions for that particular group, and it would tend to be ineffective for the individuals that might need it the most. And this can also lead, if we don't have accurate representation of the populations that we're interested in working with, then it can lead to exclusion of most vulnerable or at-risk populations. More broadly, as we're using technology more and more for research and using it in decision making, it's definitely very important for us to think about what populations are being captured in that data. So you can go to a lowest income community to do research and still end up capturing all the individuals at the top and not the individuals that are in the middle or at the bottom. And by leaving out these vulnerable populations from research, we run the risk of exacerbating existing health inequalities. So one question that is always important to ask is whether your data or tool that you've developed is helping the people that it's supposed to help, or is it biased and not really producing the results that you had expected it to produce. So I've given this talk before, and people in the past have asked about, what are some ideas of how we can address this problem? And I think here's some ideas that are worth thinking about, and I'm sure other people will probably have other ideas and other ways in which they've thought about this in their data. But it's always important to have a diverse team, because different individuals have different opinions, different experiences, and can bring in different perspectives that can make the research a lot better. It's extremely important to work with the populations that you're trying to help, especially community leaders. So if you want to work with a particular population, instead of just going in and being a foreigner asking people to give you data, you can collaborate with leaders in those communities and convince them of the value of your research, and then they can help you recruit the populations that you need for your study and help you ensure that your data set is representative of that population. I think it's important to be intentional about representation and to think creatively about ways to go about that. There are people who have developed startups that are thinking specifically about how to improve representation, whether it's in clinical trials or other types of health research. And finally, to build trust, it's important to be transparent about your research goals, your methods, and your limitations. It's not always possible for us to address all the limitations that we have in our studies, but it's important for us to be able to state those limitations clearly for people to know that they do exist. So that's all I have. These are my contributors to the study, Nina Caesar, Pallavi, Quinn, and Adaisha. So thank you so much for attending this webinar, and I think we will go to questions now.
Elaine, thank you so much for taking us to where we rarely acknowledge in this rush to embrace big data. I will open it up to the audience, but kind of I was intrigued, you reframed that big data itself can be a problem. And just wanted your thoughts on, to elaborate a bit more on technical ways of designing algorithms to advance the principles of, say, ethical social justice.
Yeah, so it's my belief that algorithms are very dependent on the data that we give them. So if the algorithm itself is not biased until you give it the data that is biased. So it's very important for us to think a lot about our data, the data that we're given to these algorithms to be trained for. So if you do present a very good data set to an algorithm, then it's going to produce results that are not biased. If you give it a really bad data set, then it's going to produce the results that are biased. And it's also important to keep going back and looking at what we're actually producing, and not just assuming that because you develop these algorithms are supposed to do X, that's actually doing exactly what you expected it to do. I think Google Food Trends, for those of you aware of it, might be one of those examples where it was important for that algorithm to be updated frequently to make sure that it's actually capturing trends in influenza-like illness in the community, and I don't think that was the case. So the algorithms that we develop are definitely very dependent on the data, and it's always important for us to keep going back and making sure that we're producing what we think we're supposed to be producing.
So pardon my ignorance, your talk was so fascinating. So, and pardon my ignorance with big data, but can you create algorithms that adjust or, as you stratify populations, African Americans by Hispanics and all, can these the parameters of these formulas, algorithms be changed so that you adjust these algorithms so you get either equal allocations, or how do you, you can control for social demographic backgrounds?
Yeah, definitely. So there are algorithms that do exist that would allow you to weight your data in different, and that's one way of going about that. So if you're creating a data set where maybe your data set is unbiased, you can also think about methods that have been used in statistics and in survey research for a long time. So survey data is something that there's been extensive research around that, and they're very well established methods in terms of weighting and looking at uncertainty in the data. So I think some of those methods can be useful when we think about data from social media sources. So how can we adopt some of those methods and apply it to these new data sources in a way that allows us to quantify an uncertainty, or at least create weights to create equal distribution across different groups.
Perfect. One last question, and then I'll open it up to the audience. So, is there any attempt to bring these kind of ethical, social justice dimensions to the training of all our data scientists who focus more on algorithms? Are there programs being developed? What is the status nationally?
Yeah, I think they are. The conversation so far has been a lot around AI, but I think there are programs. There are many workshops that are around transparency and fairness in AI research, and how we should be careful not just with the data, but also what the algorithms are producing. So those programs exist. I'm not sure whether they've been translated into academic programs yet, but at least there are workshops that people are discussing these problems.
Wonderful. Let me open it up to the audience. We have groups from different parts of the country, so please unmute yourself and feel free to pose a problem while we have Elaine's attention.
Hi, Elaine. This is Shahin from Memphis. I really appreciate your talk and lots of thought-provoking topics here. I was wondering if you had any further thoughts on, I know that you'd mentioned IRBs and the ethical, the ethical performance of these different kinds of research. And in the past, we've seen a lot of issues, particularly in vulnerable populations, lower socioeconomic status, populations in particular. Do you have any thoughts on performing this research ethically when we are able to capture these populations and these new technologies?
Yeah, so first of all, I think that we can do a little bit more in terms of IRB approval. So when I go into to talk to someone about whether my study should be reviewed, the response I usually get is, this is exempt, so you don't need to go through that process. But I think it's still important, even though we're not contacting people and asking them for more information, not everyone understands that the data that they're putting out there is actually being used for research. And so it's still important for us to be able to review the studies and make sure that we're not getting into the kinds of trouble that Facebook got into with its social contagion, which to my understanding, emotional contagion, sorry, which to my understanding actually involved some academic researchers, but it didn't go through the IRB at the university. So it's definitely a topic that I think should be discussed a lot more, and there should definitely be more improvements in how IRB handles the data that we're getting from social media and other places. In terms of vulnerable populations, that's can you hear me okay?
Yeah.
Okay, there's an echo. In terms of vulnerable populations, I think some of the things that I presented, so there's one study that talked about guidelines for ethical use. I think some of these are really good starting points. So it is very important for us to be transparent. If you're going to go into a particular population that maybe in the past has suffered data abuse, it's important to be transparent with your research objectives, your methods, and how you're going to handle your data, and also how they're going to benefit from this research. So it's not enough to just go get data, do your research, and become famous. It's important to make sure that those populations will benefit from the research and be able to go back to them and tell them, what your findings are and how they can use that to improve their health. The other points, like respecting how people publish information, not tracking people across multiple platforms unless you have some kind of consent for that and a good reason to do that. I think those are all very important rules that can be used around these types of research.
Hello, Elaine. This is Nabil from Northwestern Chicago. Thank you for an amazing presentation. Had a quick question. So regarding, so a lot of what you're presenting sort of mentions this big issue of sampling bias, right? Where the participants we intend to recruit or represent are not really representative in our data. And so, we're about to embark on a study, and a lot of tech-based studies, right, where we ask participants to sort of wear technology or use technology across a long period of time. We do notice that there is this sort of disproportionate distribution where we recruit participants that have higher SES. So what would you advise us to do, right? So you did mention, teaming up with community leaders. How do we address this issue, especially with regards to recruiting participants that are willing to wear devices? Do you have any thoughts or advice on that?
Yeah, so I think working with community leaders is definitely a good way to start if you have access to those leaders, or if you know people that can help you connect with those leaders. There are also other approaches that people are using, like network-based approaches of recruiting people. So if you can connect with someone who is in the demographic group, socio-economic group that you're interested in, and can actually convince them of the value of your study, then they can act as a catalyst to help you recruit more people. So if they actually believe your study is good and will be beneficial to them, then they can share that with other individuals in their communities and tell them, about your study, and through that way it can help you to recruit more people. I think in communities where people tend to rely very heavily on each other, the information that they get from one another, they're more likely to trust that information than trusting an outsider who tells them the same thing. So having someone who is already in the community, whether it's a community leader or just someone with a very good network within the community, I think is a very good way of increasing representation in your study.
Thank you for that.
Elaine, this is Vivek again. I'm curious. So I see the national trends where big tech is now viewed with suspicion, particularly Facebook and Google. And inside of that, for example, Apple is emerging as a firm that is more attuned to these privacy issues when it comes to guarding data. Any thoughts, any reactions to that?
Reactions to
You know how these big tech has used and the general distrust that is creeping in about the way data is being used in particularly in the US in the context of Facebook and even Google.
Yeah, I mean, I think the concerns are definitely valid. There are people that are a little bit more aware of some of the issues than others, but I don't think we are all completely fully aware of how much our data is being used and in what ways that data is being used. Some of the issues around things like data manipulation, I think, are topics that people are talking a lot about, or how that data manipulation can affect the decisions we make, whether it's will we end up voting for, or how some of that data manipulation reinforces some of our beliefs or fears about whether it's vaccines or other health interventions. But I think it's definitely valid for people to have concerns, and I think companies can play a great deal in improving public trust in how they use and how they collect data, but also how they use that data by being more transparent about their practices.
Let me ask any of the other centers participating if they have any questions for Elaine. Great. Elaine, I guess this presentation of yours was very thought-provoking as we had anticipated. We really appreciate you being here and for the wonderful work that you are doing, reframing data science also as a social justice issue and helping it push it into the consciousness of the data science community. To the audience, just a reminder that a recorded version of this webinar will be available on the MD2K's mHealth Hub. To access, go to the MD2K.org. And I want to thank you again all for joining us today, and we look forward to seeing you at the next webinar. Thank you again, Elaine.
Thank you, and thanks everyone for joining. Thank you so much.